Well, good morning, everyone. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll get started as usual with some reminders and then some logistics and introductions for the day. Please be sure to join us for next week Grand Rounds. It will be available only virtually, so you can join us on the Teams live platform. And we'll be hearing the talk, Transforming Care, Driving High-Value Care in the Post-COVID Era. And that's going to be given by Dr. Susan Wong, who is our Chief Executive for the Providence Clinical Network. I'm here today at Providence St. Vincent Southern Auditorium. Grand Rounds is a collaboration between those of us here at St. Vincent and Providence Portland Medical Center. We are often here live in person on Tuesday mornings at 8 a.m. And sometimes talks are available live also at Providence Portland. You can always find out by looking at the weekly Grand Rounds invite. We're always available on Teams Live to watch virtual, and you can earn CME credit by being here in the room, by watching live virtual, or also by watching a recording of the event, and that recording is always the same link as the Grand Rounds invite each week. I'll be monitoring the Q&A throughout today's session, so for those of you watching online, please go ahead and post any comments or questions. There'll also be some interactive polling questions from our speaker today, so feel free to jump in and speak up online. And now to introduce today's speaker, we are joined by Dr. Sham Joshi, who is a practicing allergist and associate professor of medicine and pediatrics at OHSU. He earned his bachelor's in biomedical engineering from Duke University and then returned to his home state of Kentucky to complete his medical training at the University of Louisville. Dr. Joshi completed his residency in internal medicine at Brown University and fellowship in allergy and immunology at the University of Texas Southwestern in Dallas, Texas. Trained in both pediatric and adult allergic and immunologic disease, Dr. Joshi's clinical interests include drug allergy, food allergy, chronic sinusitis, and urticaria. He also has an interest in improving healthcare delivery through operational efficiency and public health policies. Outside of medicine, I've learned that Dr. Joshi enjoys time with his family, hiking, and is still playing ultimate frisbee.
Hey, thank you all for being here. Thank you for everybody showing up here in person. I really appreciate that. It makes being a speaker so much easier. So we are going to cover a huge topic today. So food allergy there's many types of food allergies. You can have lectures on each one of them. So I've really tried to tailor this to adult-specific food allergy. And even within that, there's a big gaps that I'm going to mention that, hey, we're not talking about this today, but if there's any questions, we can definitely cover it in the Q&A session, or feel free to grab me afterwards and love to talk about it a little bit more. Just a quick plug, at OHSU, as of last year, we started the Burkhardt Food Allergy Center. So it's an entire center dedicated for just food allergy. It's mainly pediatrics, but we also do have an adult component to that as well. All right, I'm going to skip this for time's sake, but we're going to learn about food allergies. Disclosures wise, stuff that's not pertinent to food allergies. All right, let's get into some cases here. So these are probably the two most common situations we see in the allergy clinic for adult patients. So we have patient one. We have a 42-year-old female with no significant past medical history that presents to the ED for the 5th time this year alone for a concern for food allergy. She describes throat closing sensation, shortness of breath, some abdominal pain, bloating, and some headaches that are intermittent. In addition to that, she reports that each time she's had one of these episodes, it's due to a different food. And when you look at the ED notes, they reveal some upper airway noise, no rash, and no actual wheezing in the lungs. We'll come back to this in a second. So the second most common situation is we have a 38-year-old female with a history of allergic rhinitis and asthma that presents to the primary care clinic with new onset food allergies, specifically to cherries and peanuts. They describe an itchy tingling sensation in the mouth and throat, some mild nausea, and has already gone to urgent care and now carries an epinephrine autoinjector with them. So we'll come back to both of these, but keep these in mind as we move through the presentation. So probably the first and most important thing is whenever we talk to patients about adverse food symptoms, there's two big categories. You have those that are allergic and you have those that are non-allergic. The vast majority of the time, They're non-allergic. So these are what we call food intolerances. I really don't like the term food sensitivities. That's what a lot of people use, because sensitivities means sensitization, and sensitization means positive testing. These patients, there's no positive testing. Skin testing, in vitro IgE testing, it's all negative because it's not an IgE mediated process. So I typically like the term food intolerances. So we have food intolerances, but also like lactose intolerance, scombroid, we're not going to talk about today, but things like this that are non-immune mediated. Today, we're really going to concentrate on the allergic conditions. When you think about these, again, allergic conditions, these are going to be the ones that have really potentially serious adverse immunologic responses due to ingestion, versus intolerances are non-immunologic responses due to food and the body's inability to process or digest the food. These are very uncomfortable, often present with bloating, cramping, discomfort, brain fog, headaches, fatigue, but unfortunately, that doesn't really follow in the allergy world. So how common are adult food allergies? So it's really difficult to measure, because if you go out and ask people, are you allergic to foods? A lot of people are going to say yes. But when you actually dig into that, are they truly allergic? Could it be an intolerance? Could it be something else that's going on? So the numbers are really not great, not very accurate. The best data we have is from a JAMA article back in 2019. They surveyed over 40,000 adults, and 19% of them reported a food allergy. But they went a little bit further. They looked at, okay, what kind of symptoms are you actually having for this food allergy? About 10% total had a convincing allergy history. Again, not really physician confirmed, but just based off of the few questions on the survey. Of these 10%, about 45% had multiple food triggers. 24% of the 10% had an epinephrine autoinjector, which is, that in itself tells you that it's probably not really 10%. If you're not really carrying an EpiPen, that means your symptoms have not really been that significant. And then 38%, again, of those 10% have a related ER visit, which in their lifetime, which could, again, be more consistent with a true allergic reaction. Also, interestingly, in kids, it's very much a male predominance, but in adults, it's very much a female predominance. Not quite sure how to reconcile that, though. Food allergies do stink, though. They do really decrease quality of life, and it's significantly worse in kids and adults or caregivers. And oftentimes, when we are able to bring them in, talk to them about what specific symptoms they're having, do appropriate testing or food challenges where we expose them to the food in clinic, their quality of life significantly improves, because they can understand really how significant this is, how much should it be affecting their day-to-day life. But patients are often fearful of accidental reactions, hidden ingredients, and not being able to treat a reaction. And then again, the big burdens are food avoidance, label reading, when you're at the market and they're reading every single thing on the labels, and real perceived limitations of activity and levels. We see a lot of patients that are fearful for flying because they're like, if I'm in the air and I have an allergic reaction, what am I going to do? Airplanes are not required to stock epinephrine. So you may or may not have it on there. They're going to bring it with them, but they still feel very fearful of being in that kind of closed environment. All right, let's go back to case one. So again, just a quick reminder, so the 42-year-old female, been to the ER 5 times this year, new foods every single time. You get a little bit more data. So first, we know it's extremely rare to develop multiple food allergies with completely distinct chemical structures in adulthood. So that's the first thing. You're like, why is it going to be 5 foods all of a sudden? And then speaking to them, you learn that they've had similar episodes that they've had around this food, around strong odors, specifically perfumes, chemical smells, smoke. And when they describe it a little more, they report an acute onset throat tightening. They've tried albuterol in the past, because one of the ER visits they gave it to them, they found no improvement with the albuterol. And it often resolves when they kind of remove themselves from the situation. Does anybody know what this is? Close. Paradoxical vocal fold motion. So we diagnose this multiple times a week in patients that come in for food allergy evaluation. So what happens in paradoxical vocal fold motion is, normally when you take a good inspiration, the vocal cords should open up. They look like a little V. They open up to get all the air through the vocal cords into your lungs. But in these patients, they have a physiological change that actually clamps it down when you take a deep breath. And so you have a partial one in the middle and you have a complete one on the right. And it really feels like you're breathing through a closed door. So you just can't get air into your lungs. And it's terrifying. Patients are really scared because they just feel like they can't breathe. They can't take a deep breath. It's not fatal. It's not lethal. It will just open up at some point, but it is terrifying. And when patients start getting this, it continues to happen. And then they get fearful, they get anxious, and then it gets triggered more and more often. So especially in patients that have new onset of symptoms that are to many, many different triggers, if there's really throat tightening sensation, I often tell them, hey, if you go to the ER, talk to your get ENT involved, scope them, look at the vocal cords. If the vocal cords are closing in when they're taking a deep breath, that's diagnostic of this. It is not laryngeal edema. And these patients often report losing their voice. The first thing they say is like, I'm hoarse, I can't speak, but everything else is fine. They have no rash, they have no other symptoms. Think this condition. You can send them to a speech therapist, you can send them to ENT. They often will scope them, try a diagnosis. The treatment is speech therapy. And it really does work extremely well for these patients. And then they can tell them to eat all the foods that they want, and they're really happy. Okay, so when we think of food allergies, these are probably the main 5 that we're going to kind of look into a little bit today. So first you have IgE mediated, which we're all kind of aware of, right? Symptoms usually start within 1 hour after ingestion, and you get the typical anaphylaxis-like symptoms. We'll go into this in much more detail in a second. We have another condition called FPIES, or food protein-induced enterocolitis syndrome. This is much more common in kids, but we are seeing more adult onset cases. We're not going to go into this a lot because there's not a ton of data here in the adult population, and the data is quite controversial right now. But this is really in kids, 1 to 4 hours after ingestion, they vomit and vomit and vomit. Now we're not talking 1 or 2, we're talking 9, 10 times until they're dehydrated, lethargic. Again, not considered a lethal food allergy, but terrifying for families. EOE, eosinophilic esophagitis, much more common than we initially thought. Again, we're not going to have time to go into this today. This is a very fascinating type of food allergy. But really what happens is ingestion of specific types of food, most often dairy and gluten, leads to eosinophilic infiltration in the esophagus, which there shouldn't be any eosinophils in there. And over time, that inflammation can cause strictures, can cause tightening, and can cause fibrosis in the end. And these patients, any adult that presents with food infection, they should be evaluated for EOE because more than 50% of the time it's EOE. That's what it is. But we're not going to have time to go into that in much more detail. Food protein-induced allergic proctocolitis. This is really infants only up to the age of 1. This is the blood flakes in the stool with usually dairy ingestion, but can be any food, resolves by the age of 1, so we don't see it in adulthood. And then pollen food allergy syndrome. This is a really unique phenomenon. It's cross-reactivity between pollen and foods, and we'll come back to this at the end. All right. We're going to jump into IgE-mediated food allergies. You guys all are probably relatively aware of this mechanism. We're not going to go into this in much detail, but really it's antigen gets presented. For some reason, the Th2 inflammatory process gets activated at the same time. The B cells start developing antibodies against the antigen, in this case, food. These B cells eventually produce, these IgE eventually bind to mast cells, and then they hang out on mast cells until that antigen is presented again. When you eat it again, activates these mast cells, degranulation, histamine release, tryptase release, and you get the typical IgE-mediated symptoms. There are some key factors here. So whenever you're investigating somebody for food allergies, these are the 5 things you really want to think about. First, timing. Are the symptoms happening within 1 hour, typically after ingestion? If these symptoms are happening the day after, it's extremely unlikely to be a food allergy. Frequency, it should happen with each ingestion of the food in the vast majority of cases. So if they're saying, I ate eggs one day, but then the next day I ate it and I was totally fine, it's not an egg food allergy. Done. Ask about other products that contain foods. This often happens. People will come in and say, I can't drink milk. I have or get a rash every time I drink milk, but they can tolerate cheese, yogurt just fine. And it's like, well, it's not a protein. It's not a milk protein allergy. Done. Look for the typical symptoms. Again, these are the symptoms you're looking for. If somebody comes in without any of these symptoms, but they report headache, it is extremely unlikely to be a true food allergy. Always ask for pictures. This is huge. I would say over 75% of the time when somebody comes in and says they have hives, it is not hives. And if they bring you pictures, you can actually tell, are these urticarial lesions or are they completely different? And most of the time it's completely different. But patients don't understand the difference between urticaria or hives versus any other type of rash. And understand what medical intervention was used. Oftentimes, if they get diphenhydramine or steroids or whatnot, and they get better, that's helpful information. If they use these medications and nothing gets better, the rash doesn't get better, again, very unlikely to be a food allergy. And then look at personal and family history of A to B. It all plays an important role. So this kind of goes back to that initial slide on the prevalence of food allergies. This was a really cool study they did in 2023, so just last year. And they looked at a bunch of patients that had reported food allergy. And they found on this kind of grayish bar that these are the patients that had a reported food allergy. And then the purple bars, okay, we looked at the history, and it's somewhat convincing. And then you look at the dark kind of grayish bar, that, or maybe green, that was physician confirmed. And you can see the vast majority of the time, patients have much higher reported food allergies than they do actual physician confirmed allergies. If it's significant enough, most of these patients are going to a provider to figure out if this is a true allergy or not. So if they haven't, it's probably very minor or it's not really a food allergy. You can see milk is the highest reported. Probably a lot of those cases are lactose intolerance. But shellfish is number 2, and then you get kind of to the rest with peanut, tree nuts, and wheat. All right, first polling question. So if you take out your cell phone, you can scan the QR code here. So let's say somebody truly has a shrimp allergy. You did blood testing, it's confirmatory, their history is very consistent with an IgE allergy. What are you going to tell them about other crustaceans? Are you going to say, hey, very unlikely to be allergic to them, about 5% cross-reactivity risk, 10%, 40, 60, or 75? We'll give everybody 30, 45 seconds. People virtually can also do this. Just scan the QR code and put it in. See if we can get to 25. All right, 20 is good enough. Okay, so most people said 10 or 40%, and we have a few scattering of the rest. The actual answer is 75%. So when you look at crustacean shellfish allergies, the risk of being allergic to other crustaceans is about 75%. But if you look at mollusks like clams, mussel, oyster, it's a little bit less than 50%. There's not a ton of data there, but you're more likely to be able to tolerate mollusks. If you look at kind of the bottom graph or the bottom line here, we're looking at finned bony fish. So the cross-reactivity, the chance of you being allergic to another finned bony fish is around 50%. But if you look at cartilage-based fish like sharks and dogfish and rays, that cross-reactivity is actually very, very, very low. So just some stuff that we tell patients. Still okay for the most patients. I probably wouldn't test them for shark and just be like, you're probably fine, go for it. Unless they're super concerned or something, we'll do it. But or if they don't like it, that's a whole different story. All right, some more cross-reactivity. These are always interesting to look at. So let's look at peanuts. So people who are allergic to peanut, the chance of them being allergic to tree nuts is about 1/3, so 33%. The chance of them being allergic to sesame is a little bit higher, 10 to 15%. And other legumes. Peanut's not a nut, right? It's a legume. And so being allergic to other legumes is pretty low, somewhere in the 5 to 10% really. Soy is a little bit higher, but 5 to 10% in those patients. If you're allergic to another legume, what's the chances of you being allergic to peanut? Pretty high. Tree nuts. If you're allergic to one tree nut, you have about a 15 to 33% chance of being allergic to another tree nut. So again, there's a lot of people out there that are just allergic to, let's say, cashew and pistachio, but can eat every other tree nut. So it's important to find that information out because it does open up a lot of foods for these patients. And this is always a great one. So people who are truly allergic to cow's milk, but they come in and they're like, oh, goat cheese is great. Like, you're not allergic to cow's milk then. Like, the cross-reactivity is way over 90%. And so you can't there's something different there that's going on. It's not actual milk protein. If they really do want to drink some form of milk, the two that are the most tolerable are camel milk and mare milk. And if you've ever tried them, they are gross. They don't taste great. And then very small percentage, 10 to 20% of people who are milk allergic can actually have symptoms with beef as well. It's probably not even that high, but that's what the studies have shown so far. Yeah, we'll talk about that later. Yeah, stone fruit's a big one. Okay, so when you're thinking about making a diagnosis of food allergy, by far the #1 most important thing is clinical history. If the clinical history is not appropriate, doesn't fit with an IgE-mediated food allergy or some of the other food allergies we talked about, don't go down the path of testing. That's as simple as that. There are a bunch of different tests that are out there, though. You can do skin testing, which mostly is going to be done in an allergy clinic, in vitro IgE testing, which is going to be available for everybody, in vitro IgG or IgA testing, you have patch testing, gastric juice analysis, hair analysis. This stuff is really, it is actually done in the community here. I've seen many patients with this stuff. Leukocyte, histamine release tests, applied kinesiology. When you go to actually the data of what is helpful in diagnosing a true food allergy, you have, this is one of the fantastic IgG tests. None of these actually do anything. They don't tell you anything that's clinically relevant for you to actually give patient information. The problem with in vitro IgG testing, so IgG testing to specific foods has been around for 60 plus years. This is not new technology. It has been around for so long. They've looked at it for many different applications. They've looked at it for food allergies, food intolerances. They've looked at it for celiac disease. They've looked at it for IBD, so many things. And it has been found to be completely useless. And that's why it's starting to be marketed directly to patients, because patients don't have that information. And they're like, oh, yeah, let's do this. Let's see what I'm sensitized to or what I'm intolerant to. But what the body does, so when you eat food, food is a foreign substance, right? So our body has to decide, is this foreign substance okay? Or is this foreign substance really bad and I need to attack it with the immune system? When you ingest it through the GI system, one of the ways that your body marks it as something to be okay or to be tolerant of is producing IgG against the food. Because what happens is that IgG binds to the food in the GI tract, or IgA, binds to the food and prevents IgE from binding to it or preventing other T cells or for recognizing it. And so it protects it to get through the GI tract, through the immune system part, and for us to actually be able to ingest it. So when you're getting IgG test for foods, all you're looking at is, what foods do I normally eat? So if you look at the typical American, you're going to have really high IgG to milk, to eggs, and to wheat, because that's the American diet. And then when patients look at that and they're like, oh, this is what I'm intolerant to, they remove those things from their diet, which is a way healthier diet, they feel better. It's like, yes, just go to a Mediterranean diet from the beginning and you're good to go. So they've looked at studies looking at, if you use the IgG testing to determine which foods to eliminate to feel better intolerance-wise, or if you just prophylactically go to a Mediterranean diet, the Mediterranean diet is still better. It's just, you're just eating healthier. So when people bring you these IgG tests, you can tell them with confidence that this has really been looked at. This doesn't tell us anything that's really clinically relevant. I could have guessed which ones are going to be positive just based off of your diet. So we don't like those tests. And all these other tests are really not proven at all. And so we really stick with in vitro specific IgE food as well as skin prick testing. And they're both testing for the same thing. Okay, so in vitro testing, there is a bunch of foods that are available. If you go through ARUP, there's, last time I checked, was 139 foods. If you go to Mayo Clinic, there's over 150 foods. These are helpful tests, but again, you're only checking for the foods that their history is really consistent with an IgE-mediated allergy. If they have an intolerance, they get headaches when they eat milk or drink milk, this test is useless. It's not going to tell you anything because it's not an IgE-mediated process. There's also something called component testing. So when you do allergy testing, let's say to peanut, there's a ton of proteins there, and you can have IgE to specific parts of the peanut that are not clinically relevant at all. So these IgE could be floating around, they bind to some random part of the peanut, doesn't cause any issues. But there are very specific proteins that we know in peanuts, ARAH1, ARAH2, ARAH3, ARAH6, ARAH8, and ARAH9. These specific proteins have been associated with clinical allergy. So you can do component testing if you're not sure based off of general testing. Usually that's going to be kind of the allergist's job to decide if that's really helpful or not. You can do it for cashew, hazelnut as well. We know it's not very helpful for milk components or egg components. And then the newest kid on the block is epitope testing. So even within the protein, there are different parts of the protein that if you have an IG to a very specific epitope of a protein, you're much more likely to have a clinically relevant food allergy versus a different part of the same protein where you're less likely to have it. So this is only commercially available for peanut. I have never ordered it because I've never really found a need to order it, but it does exist. And so maybe in the future, this will become a bigger thing. This is always a big question we get is, oh, the patient's worried about a bunch of foods. Can we just order the food panel to see which ones may be clinically important and which ones are not? The short answer is no. Never, ever, ever order a food panel. And we'll talk about why. So especially in adults, there is an extremely high risk of false positives. We know the sensitivity is about 85%, specificity is about 40 to 80%, but this is from all comers. This is kids and adults. When you look at adults, the sensitivity is extremely low, extremely low. The positive predictive value for IG testing for adults without a history consistent with it is probably less than 20%. Like you are going to get a ton of false positives. So if the more tests you order, more likely you're going to get a positive. If I tested myself for 100 things, 15 will probably come back positive. I have no food allergies. And so when I give that example to patients, they are often like, oh, yeah, that doesn't make so much sense. Let's not get the whole panel. I know it's kind of hard to convince patients sometimes. But we also know that food allergy panel testing often results in misdiagnosis of food allergies, overly restrictive diet avoidance, and an unnecessary economic burden on the healthcare system. It does make a difference to the patients. My favorite is a patient goes to X provider. They get a food panel done, and it comes back positive for like 10 things. And the patient comes to see me, and they're like, hey, these are my results, not sure what to make of it. And I'm like, well, what did the provider tell you? And they're like, they said, you don't really need to avoid these if it's not bothering you. I was like, why'd you order it then if you're not going to actually listen to the results of the test? So they clearly knew that the testing is not great, then don't order it. Only for those specific foods that you are really consistent, that the history is consistent with, order those individual foods. Don't order a bunch of junk. So why is testing so crummy? So there's a lot of factors that play a role here. So the arrow up means that the testing is more helpful, and arrow down means it is less helpful in that situation. So first we have, if a history is consistent with an IgE-mediated allergy, then the testing is, again, very helpful in that situation. In younger patients, it can be more clinically relevant. And so in adults, less likely to be actually correct. In Black ethnicity, not sure why exactly, but these patients often have more false positives, especially for foods. Patients with eczema. So eczema causes total IgE levels to go up, right? So if total IgE levels are up, then obviously each specific IgE is also going to be up. Concomitant inhalant allergies. This goes back to the pollen food allergy syndrome, which we'll come back to. Just patients in general who have atopic disease, their total IgE is elevated. And then there's a lot of geographic variation. So when you look at studies from Pacific Northwest to the Southeast, it's not consistent. Okay, treatment. Big things, reducing risk of developing food allergies. So this is really about the early food introduction that you may hear about, especially when you're counseling new parents. We know earlier food introduction in the moderate to severe atopic children reduces the risk of food allergy. And that's, again, going back to exposure through the gut produces IgG and develops tolerance versus exposure through the skin, through eczema skin, likely leads to IgE sensitization. Not really helpful in adults. Strict avoidance. That's really the mainstay. Education, how to avoid, regular testing if a patient has a chance to outgrow it, and then carrying an epinephrine auto-injector. There are other options as well. Immunotherapy, so oral immunotherapy, which is desensitization to the food, really works great in young children, not so much in adults. Sublingual immunotherapy, same thing, better in kids, not so helpful in adults, at least with the data we have so far. And we also do have a medication that's actually approved for food allergies, which got approved in February of this year. It's called omalizumab, which is something that we often use for asthma, chronic hives, nasal polyps, but now for food allergy. It does not cure food allergies. All it does is raises the threshold of reactivity. So instead of reacting at 1/10 of a peanut, patients can often tolerate 5 peanuts before reacting. But if they ate 35 peanuts, they're still going to react. So you still have to carry an EpiPen around, still have to avoid it, but does produce some increase in tolerance. The most patients that take this are the ones that are really young kids that are transitioning to daycare or elementary school. I haven't had a single adult that really wanted to do it. The big things with avoidance, we kind of went through this. There are multiple treatment options, different types of epinephrine autoinjectors, and I just want to highlight this one in the bottom left here. This is a intranasal epinephrine administration. So this was just approved about a month ago. And it's a higher dose. It's 2 milligrams in the nasal versus usually 0.3 in the auto injectors. And it works equally as well with the data we have. It's only approved in patients 30 kilograms and heavier, which is every adult, but not available for young kiddos yet, which was probably the population that needs it. But it looks like Narcan, right? It looks exactly like that. It's probably the same mechanism, but it is definitely an option, and it's covered relatively well by their pharmacy kind of plan. So if somebody's really afraid of needles and they're never going to give themselves epinephrine and they need it, that's a good option for them. And most also very important is if they ever have an accidental ingestion and they have symptoms, get a tryptase level. Tryptase is exclusively released from mast cells. And so it is a clear marker of IgE-mediated allergies or any kind of mast cell-mediated anaphylaxis or hypersensitivity. Tryptase levels are fantastic. Especially, I've been trying to implore the ER to do it whenever somebody comes with an allergic reaction because it gives us a ton of information afterwards. Was this truly an allergic reaction, or was this paradoxical vocal fold motion or something else? The tryptase level can help us determine that. So super important lab. Always, you can give patients food allergy action plans. They appreciate it. It takes 2 minutes to fill out. The most common one we use is from the FAIR over there. It's Food Allergy Research and Education. You can download it online. It's free. And just fill out their name and kind of what symptoms to look out for and what medications to take in those situations. All right, next poll question. What is the optimum dose of intramuscular epinephrine for an adult 70 kilograms currently in anaphylaxis? So you can give them 0.15, 0.3, 0.5, or 1 milligram. All right, for time's sake, we're gonna move on here right around 20. All right, 0.3, everybody. Not everybody, most people. There isn't a right answer here. We actually have no idea. In our clinic, we always give 0.5, and there's more and more data coming out that 0.5 is probably better than 0.3 without any increased risk of side effects. There was a great study that came out of UC Davis, I believe, a couple of years ago. And they compared the outcome of patients that got 0.3 milligrams versus 0.5 milligrams. The patients that got 0.5 milligrams had a much lower risk of needing a second dose of epinephrine and were able to be discharged faster. And so at OHSU, we're actually conducting a study right now that we're transitioning pretty much the whole healthcare system from 0.3 to 0.5, and we're going to track the outcomes. But I anticipate that we're going to have patients leaving the ER much faster, that admission rates to the floor as well as ICU will probably be much less. The risk of intubation will probably be much less. This 0.3 is it's completely like, we're just going to pick a random number and make epinephrine autoinjectors out of 0.3. If you look at it across the world, Canada has a 0.5 EpiPen. Many countries have 0.5 milligram epinephrine autoinjectors. The US just doesn't. But it does seem to be anybody over 50 kilograms probably should be getting 0.5 milligrams. And so we do that in the allergy clinic. We're hopefully going to be launching it very soon across the institution. All right, let's go to anaphylaxis really quick. So acute onset, there's many definitions of anaphylaxis. Oftentimes people want to see respiratory compromise or reduced blood pressure. Another definition is any two systems, as long as two systems are involved, that's anaphylaxis, or a reduction in blood pressure after a known allergen exposure. When it comes to this, we really look at this middle one. We consider anaphylaxis to be anything that is too system involved and doesn't have to have respiratory compromise, doesn't have to have hypotension yet, because you're going to catch a lot more cases of early anaphylaxis and treat them early enough that they don't progress. One of the biggest risk factors for severe or poor outcomes to anaphylaxis is late administration of epinephrine. Just give them epi. It's very safe to give it intramuscularly. I'm not telling IV like worry about coronary artery disease and stuff like that. If you give it to them IM, it's extremely, extremely safe. One question we always get is biphasic reactions. So this isn't just for food allergies, but also for food allergies. What's the risk of this? And so a biphasic reaction is after the symptoms have kind of resolved, they got treated, usually 2 to 48 hours later, usually somewhere in that 4 to 6 hour range, they have recurrence of symptoms. And that's one of the main reasons why the ER is always often like, hey, we're going to keep and watch this patient for 6 hours after their reaction just to make sure. It's pretty rare. Most recent studies have shown really the risk is about 4 to 5%. And then really clinically significant events is 0.18. So if they get one hive 4 hours later, technically a biphasic, but really clinically significant 0.18%. Very rare. Deaths have been reported, but those were not clear-cut due purely to the biphasic reaction. Again, these are on average about 10 hours after resolution of the initial symptoms, and can be as long as 38 hours afterwards. Many theories of why this happens. Could it be an uneven antigen absorption? So some of the food protein got in there a little bit later, or the initial therapy wearing off. We're not quite sure. But when you look at what are the highest risk factors for a biphasic, so this was, again, a meta-analysis looking only at 86 cases, so very small meta-analysis because there's not much data out there, that having initial severe symptoms may put you at higher risk. Also, if you required more than one dose of epinephrine, may put you at higher risk for a biphasic. Those make sense. But what's missing from this, and what they looked at but was negative, was therapy with antihistamines and steroids. So likely risk factors: more severe initial presentation, needing multiple doses of epi, maybe some other risk factors you can read here. But the Joint Task Force in Allergy came out with this in their practice parameters just a few years ago. Did not identify significant benefit in prevention of biphasic anaphylaxis from H1 antihistamines, H2 antihistamines, or glucocorticosteroids. We do not give patients steroids when they have anaphylaxis. There's no data to support it at all. We just avoid it. There's many side effects associated with it, but we know that there's no actual benefit there. So we don't give anybody steroids. Sometimes we give them an antihistamine, but we do not give steroids. There's actually some data in young kids, very small amount, that it may actually increase the risk of biphasic. We have no idea why, but the evidence is really low overall. And so we feel strongly about steroids. We don't do it. Really, managing biphasic is education. Hey, if a patient has some minor symptoms, what should they do in those situations? And again, it tends to be lower rates if you give epinephrine early on. The risk of biphasic goes down. And we know steroids and antihistamines don't make a difference. So the big question is, how long should we monitor these patients? Should we monitor them for an hour, 6 hours, 10 hours? This is a really cool analysis that they looked at over 1,900 biphasic reactions. So a huge meta-analysis. And they found that 95% of the time, you're not going to get a biphasic if you just watch them for an hour. They're not going to have any issues. Because again, the risk of biphasic is so low. If you watch them for 6 hours, you're catching 97% of them. If you wait for 12 hours, you're catching 98% of them. If you wait for 24 hours, you're catching 99.4% of them. So if we're going to catch every one, let's watch them for 24 hours. But is that really important? So then they looked at what is the number needed to treat to catch a biphasic beyond the 1 hour timeline. And they found that you need, for patients that have severe initial anaphylaxis symptoms, these are, again, higher risk than normal, you needed to watch 41 patients for an extended period of time to catch a clinically relevant biphasic. Is that really necessary? Probably not. And then if you had multiple epinephrine doses, then it was just 1 in 13. You needed to watch 13. So maybe if you have multiple epi doses, you should watch them a little bit longer. But you can make the argument that most patients, you should just be watching for 1 hour and letting them go. In our clinic, anaphylaxis happens all the time. We're giving allergy shots, food challenges. We watch them for an hour. We give them epinephrine, symptoms resolve, watch them for an hour after the symptoms resolve, and we let them go, and they're fine. So this is, again, just summarizing. There are some things that you may want to watch them longer for, but really there's no consensus still, unfortunately. Then they looked at kind of a cost analysis. All right, let's see how many patients do you need to treat, or how many patients, just based off cost analysis, is it worthwhile to watch them 6 hours versus the 1 hour observation period? And they used all these metrics in here. And they found that if your willingness to pay is around 10,000, there's clearly no benefit. Even if it's at 100,000 for a biphasic, you're not even anywhere close to being a viable model. So my big push is, as an ER, we should be risk stratifying these patients and letting them go after an hour if they're doing just fine, because it is extremely cost ineffective. Then they looked at, okay, if the direct hourly cost, at what level does 6 hours not make much of a difference? And it has to be around $48. The direct cost right now is around $300, $400 for these patients in the ER, where it has to go down to $40, $45 for it to be actually appropriate from a financial standpoint. These are rare. Waiting in the parking lot, that's the parking lot rate's expensive. That probably doesn't make it cost effective there either. But even with that, most patients are just wasting a spot, and we don't tell patients to do that. Yeah, so the question is, if they're at home and they have anaphylaxis, they have an EpiPen, what do you tell them to do? If it's their first time they're having anaphylaxis, I tell them to come into the ER. If this is something that they've had multiple times, they've been able to manage it, 1 EpiPen dose has usually been good enough, and it's happened 3 or 4 times, then I often tell them, hey, if you feel comfortable, you don't have to come in necessarily. And there's more data supporting that now. But if it's a first, second time, come in, let's figure out how this is going to go. All right, ticks. We're going to talk about ticks and food allergy. Eating ticks is not what we're going to talk about, though. So this is the Lone Star tick, and you can see when it starts drinking blood, it gets quite engorged here. So what's the story with food allergies and ticks? So many years ago, there was at University of Virginia, they started noticing that patients were getting anaphylaxis to the first dose of cetuximab. First dose anaphylaxis is very unlikely because you have to get sensitized first before you develop IgE. And they also found it infliximab, rituximab, vedolizumab. All of these were causing first dose anaphylaxis. They also noticed that the only places reporting this were in the Southeast, mainly Tennessee, Kentucky, North Carolina, Virginia area. Then they found, oh, there is this pre-existing IgE to alpha-gal. Alpha-gal is a carbohydrate moiety and found in non-primate mammalian meat and gelatin. And these patients all had alpha-gal. Like, okay, maybe there's a correlation here. So what is alpha-gal syndrome? So alpha-gal syndrome is when a tick, specifically a Lone Star tick, goes and bites a non-primate mammal. So like a deer in this case. They have alpha-gal in their system. And so it takes some of the alpha-gal with it, goes around, and then bites an unintended host, like a human. And that causes some of that alpha-gal to be entered into the human. We think something with the saliva activates a Th2 inflammatory process, which causes IgE class switching, and you develop IgE to the alpha-gal, which was just introduced into the body. And now this IgE is floating around against alpha-gal, binds to mast cells, hangs out and waits there until the human eats a red meat, like deer or cow or pork. And then that IgE gets activated and causes mast cell degranulation, and you're allergic to all red meat all of a sudden. And so if you look every 2 or 3 years, this becomes a huge deal. Every news company picks it up, like alpha-gal, 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 and talking about it everywhere. This just happened last year. So this year will probably be fine. Next year it'll probably happen again. But we know about 500,000 people in the US have alpha-gal, and you are going to see it here in Oregon. So these patients, interestingly, have a delayed IgE-mediated allergy, so 2 to 6 hours after exposure. Why this happens, we're not sure. We think it probably has to do with the carbohydrate actually being ingested. It's not as quickly ingested as proteins are. It's a little bit lower in the GI system, so by the time it actually gets into the system and then gets recognized by the immune system, it's a little bit later than the typical. So these are the patients that went out for a steak dinner, woke up in the middle of the night, vomiting, hives, and everything. So they went to bed just fine, but it's a little bit later. So when I said IgE-mediated allergies happen within 1 hour, this is the one exception. 2 to 6 hours usually later. But typical anaphylaxis symptoms: urticaria, angioedema, anaphylaxis, vomiting, all that fun stuff. There are augmenting factors. So especially if they had some wine with dinner, more likely to have a more significant reaction. Exercise, NSAIDs, these all augment allergic reactions. And they can have some other contact manifestations. They can contact urticaria. So if you work, these are for veterinarians that work with bovine amniotic fluids, so giving birth, they can get rashes all over where they came in contact with, as well as nodules in that same situation. The good thing is the testing for this is fantastic. You can do specific IgE testing to alpha-gal, and sensitivity is 100%, specificity is 92%, but 2% can have a negative IgE testing. There's a condition called pork-cat syndrome as well. So if you're super allergic to cat, specifically one protein of cat called FeLD2, it actually has an analogous protein in pork, and you can have an allergic reaction to pork because you're super allergic to cat. IgE declines over time, and a repeat exposure can cause IgE to kick back up. You can do skin testing to like the biologics that have it. That's much more expensive. Just get the blood testing. These patients are generally more atopic, and having atopic disease increases the risk of severity for these patients if they have alpha-gal. So when you look at the cases of alpha-gal, they're clearly centered kind of right in that southeast area with those states that I talked about. But if you look over here in Portland, it's not completely white or gray. There are some cases that are being reported here. I would say the vast majority of patients I've seen are patients that have moved from Minnesota or the southeast, but I have had some patients that haven't had a significant travel history and are clinically positive now. So why is that happening? The Lone Star tick distribution is really, again, in the southeast. It is, with climate change, it is creeping out of the southeast now. So we're seeing it travel more north, more west, getting all the way up into Maine now, which it never was 10 years ago, and in Minnesota, which it never was 10 years ago. But we've seen a huge increase in Minnesota, actually, specifically. But it is also moving out west, and we have seen Lone Star ticks in the area as well. But also, we know that alpha-gal is present in other parts of the world that don't really have Lone Star ticks. So when you look at Australia, the Ixodes species can also cause this condition. We have Ixodes here in Pacific Northwest. Another Ixodes species, that's the prominent one in Europe. And then, I can never pronounce this, I'm not going to try. This tick species in Asia is a common cause of alpha-gal. So we're seeing it across the world now. This is probably going to become a bigger and bigger phenomenon. So what do you tell patients if they have alpha-gal and they love beef or pork? Yeah, Mother Nature's revenge, exactly. Avoidance. So they can tolerate poultry, fish, shellfish, just not red meats. There are possible ways to decrease their sensitization, again, with omalizumab that could decrease their level of symptoms if they have some exposure. But there is also something called GalSafe, which is alpha-gal-free pork. So you see this, no AGs, no alpha-gal. This is actually available here in Portland. And so if patients really, really want their pork, this is one way that they can get it, and because it doesn't have any alpha-gal in it. All right. I love this image. This is my favorite thing, especially if I'm giving a talk in May and people are all miserable with grass pollen. It's very true. All right, so let's go back to case 2 and then we'll wrap up here. So our case 2 is our 38-year-old female, history of allergic rhinitis, history of asthma, primary care, new onset food allergies, cherries and peanuts. They get that tingling mouth sensation. You get some additional history. Last week, grandmother baked a cherry pie, and they actually did okay with the cherry pie. And they also recognized that some of their symptoms are generally worse in the spring. Here's the last poll question. What condition does this patient have? Do they have new onset food allergies to cherries and peanuts? Do they have eosinophilic esophagitis? Do they have pollen food allergy syndrome? Or is this a new food intolerance? All right. Love it. It probably makes sense because of the title, but Let's talk about it because this is the most common food allergy we see in adults. Like not even close. So when I trained at UT Southwestern in Dallas, we didn't see much of this because they didn't have significant pollen sensitization to specific things that cause a cross-reactivity. But up here in the Pacific Northwest with grass and birch pollen, very, very, very common. So this is an image stolen from UpToDate. So if you have access to UpToDate, you can totally pull this up. It's a great image. I love pulling it up for patients and going through it with them. But what pollen food allergy syndrome really is the proteins in these pollens, so specifically birch pollen has a protein called BETV1, is analogous to a lot of proteins in other foods. And so what I tell patients is, hey, your body thinks you're eating a handful of birch pollen and it's causing an allergic reaction locally. So these patients often report itchiness is probably the predominant thing, some tingling, sometimes they say numbness. It can be in the mouth or throat, not life-threatening, but it can be in mouth or throat. Very rarely you're going to have anything beyond that. Less than 3% of the time, you're going to have some systemic symptoms. Almost all of that is usually nausea, rarely vomiting, and extremely rarely to be anaphylaxis. I don't give patients epinephrine autoinjectors for pollen food allergy syndrome unless they've had full-blown anaphylaxis that's been shown, because it is usually not needed. So we usually do environmental testing instead of food testing specifically to confirm they have birch pollen sensitization. So you can see up there, birch cross-reacts with apple is a big one. Stone fruits, this is what you're asking about. So this is what it is. If you're allergic to a bunch of stone fruits, it's pollen food allergy syndrome cross-reactive to birch. But peanuts, soy, some bunch of spices. So ragweed, the big ones are going to be banana and the melons. For mugwort, it's going to be a lot of the spices again, but onion and peach are some big ones for that. And then the grasses, tomatoes and orange, as we see a decent amount up here, again, because people are so allergic to grass pollen. Treatment, avoidance, I don't tell people to avoid. If they want to avoid it, they can avoid. If they can want to deal with the symptoms because they love the food, go for it. We do know that symptoms are worse during peak pollen season. So if they're eating these foods right now, they're probably not going to have many symptoms. But if they eat it during peak spring, they're going to have a little bit more symptoms. You can peel. So apples specifically, you peel the skin. Most of that protein is in the skin. They can often tolerate it if you peel it. If you bake it, so that denatures the protein and they no longer have an issue. That's why that our patient could tolerate cherry pie, but not fresh cherries. Or you can just microwave it. Throw in the microwave 15, 20 seconds. That'll also denature it pretty well, but kind of weird microwaving cherries, but some patients will. So I tell them to microwave it and then stick it back in the fridge so it cools down again and then eat it. And it's usually okay. They can take an oral second-generation antihistamine prior to eating these foods if they know they're going somewhere where they're going to eat it. That can decrease symptoms as well. And then the environmental allergy shots may or may not help. There's not a ton of data there. In my experience, it's about a 50-50 chance. But if patients are really limited in their diet, we do often go to this to allow them to eat more foods. All right, take-home points. Food allergies are often, adult food allergies are often reported, but very few are confirmed. If patients have interest in learning more, talk to them about it and consider testing when it's appropriate. History is key when considering ordering allergy testing. If the history is not consistent with an IgE-mediated allergy, don't order the testing. For eosinophilic esophagitis, for FPIES, for any other type of food allergy, not IgE-mediated, not helpful. Any food intolerance, not IgE-mediated, testing is not helpful. It's really frustrating for patients, but it's explaining to them that you're pretty much asking for an x-ray of your hand when you have foot pain. It is not meant for that kind of situation. Don't order it. Epinephrine is the preferred treatment for anaphylaxis. Don't wait. Don't give them antihistamines. Don't give them steroids. Give them epinephrine if they have two-system involvement. They're going to feel better faster. They will get out of the hospital faster. It's the right thing to do. Reduce the risk of severe symptoms. Biphasic reactions are extremely rare and generally do not require extended observations times. I would argue 1 hour is adequate for the vast majority of patients, unless you have severe symptoms or multiple epinephrine doses. And alpha-gal allergy is a growing phenomenon, and you will see cases up here in the Pacific Northwest. And so if you're thinking about this, delayed reaction, symptoms are inconsistent, eat a decent amount of red meat, get alpha-gal testing. It is appropriate now. In like North Carolina, everybody gets tested because they're so common. But here, use some discretion, but it is, I've seen many, many cases. That is it. We still should have some time for questions. And again, thank you all for coming in person and thank you all for who's joining virtually. Appreciate it.
Fabulous. Thank you so much, Dr. Joshi. We'll take any questions here in the room.
I was so interested in your cross-species things, and you mentioned the cat.
Yeah.
Can I go outside of food allergy and ask if the cat eats that cat food that's sold?
Yes.
That's supposed to reduce the protein that they're then licking off their fur. Is that a real thing, or is that marketing?
No, it's real. So there's 9 different proteins you can be allergic to in cats. And that's some of that's in the dander, some of that's in the saliva or albumin, and some of that's in the urine. And out of those 9, there's one that's most common. That's called FeLD1. But you can be allergic to FeLD 2 through 9 as well. The cat food that is marketed, that if your cat eats this, it does decrease the amount of FeLD1 that's produced. But if you're allergic to FeLD2, it does nothing for you. And there's no great test. There are some stuff out there, but they're not great to decide which fel that you're allergic to. So like the Siberian cat naturally has way less FeLD1. So a lot of people can tolerate a Siberian cat that can't tolerate other cats, but you don't know what your mix is really. The one thing that is marketing is hypoallergenic dogs. That doesn't really exist. Same kind of issue. You have a little bit different protein profile, but there's not a single allergen that's as prominent. Like for cat, FeLD1 is the big one. For dog, it's not as prominent. So some people may have issues with certain dogs, not other dogs, but it's not because they're hypoallergenic. It's just that dog breed is a little bit better tolerated for that specific patient. Yeah. That was a very long answer for a very short question.
This is really helpful. Thank you so much. I was wondering about the study you were talking about regarding the biphasic reaction. Did they have a clear definition? It sounds like when you were talking about it, people define it very broadly.
Yeah,
but
that's a big problem. So even in the meta-analysis, they did comment on the fact that the definition is not consistent, but generally is after complete resolution of symptoms, development of new IgE-mediated symptoms. So that can be as small as a single hive, or it could be full-blown anaphylaxis. And there's no study that I'm aware of has really graded that and like separated out the more severe versus the milder ones. They're just taking out all comers for. It's just such a small number. That's the issue, right? Like when we look at it, we're talking less than 0.2% of patients. And oftentimes these patients are in a situation where they're getting treated quickly and they're either being discharged before they can actually watch in that whole period of time. If they had some minor symptoms at home, they're not reporting it. So like it's a really hard thing to study, unfortunately.
Thank you so much. I'm a dietitian, and I actually had an alpha gal person here last week. I didn't get to talk to her though. She was in neurocritical care about it. My question is about MCAS.
Okay. I intentionally left it out of this presentation. I give 2-hour lectures on MCAS. It is a very complicated condition. So how I talk to my patients is when they come in with a question of MCAS. MCAS is mast cell activation syndrome. Mast cell disease is a spectrum of conditions. You have very severe types like systemic mastocytosis, cutaneous mastocytosis, and you have very mild, technically mast cell activation syndrome, like environmental allergies is considered mast cell activation syndrome. What patients are really referring to is this idiopathic mast cell activation syndrome. And so their mast cells are degranulating without any clear cause and causing IgE-mediated symptoms. First and foremost, you have to really understand what symptoms they're having, because if they're coming in with fatigue and headache, that's not MCAS. But if their main predominant symptoms are itchiness, flushing, hives, nausea, vomiting, maybe. But you really have to get the objective evidence. And I think 99% of the people don't take the time to get the objective evidence. And you need that to really make the definition. And how you do that is you get a baseline tryptase level when they're feeling fine. And then you tell them, you give them a lab slip and say, when you're having a flare of your symptoms, go and get another tryptase level. Tryptase, again, is exclusively released from mast cells. So if the symptoms are associated with mast cell degranulation, their tryptase should go up. There is a formula that you use. It's 20%, so 1.2 times their baseline tryptase plus 2. If it increases above that number, that is consistent with mast cell degranulation and may be consistent with idiopathic mast cell activation syndrome. If they can never do that, I don't put that label on them. And I make it I put a hard line in and be like, we can't keep treating you like this unless we actually know what this is. If a patient has constant symptoms all the time, then it's not mast cell activation syndrome because it should be episodic. And so we kind of rule it out from the beginning there. But sometimes you do have to go through the multiple steps to really convince patients that this isn't, it's a new hot thing, right? Everybody has POTS, everybody has hypermobile EDS, and everybody has MCAS. And that triad, the triad doesn't exist. That's a really bad study that triad came out of, and it's really terrible. But people come all the time with this condition, and it is hard convincing them because we have limited tools. But if you go through the time and really working with them, most patients are happy to not have that extra diagnosis on their chart. Yeah.
Great. Thank you for your willingness to cover MCAS in 1 minute. We'll have to have you back again. Thank you, Dr. Joshi.
Of course. Thank you all.